Hey guys, welcome back to my channel Harrison Learns. Today we are tackling a fascinating chapter from pulmonology, disorders of the pleura. I am going to break down about pleural effusions and pneumothorax. Let's dive in. First off, a quick reminder. Pleura is that a thin membrane covering your lungs and lining your chest cavity. It is normally has a tiny bit of fluid for lubrication, but when things go wrong, we get disorders like pneumothorax and pleural effusions. Starting with pleural effusion. This is basically an excess buildup of fluid in pleural space, which is the gap between the lungs and the chest wall. Normally, the fluid enters from capillaries and removed by lymphatics. But if this removal is slows down or production ramps up, boom, it causes effusion. There are two main types. One is transudative, another one is exudative effusion. What is transudative effusions? Basically, they are watery, protein poor fluids caused by imbalance in hydrostatic pressure and oncotic pressure. What is this hydrostatic and oncotic pressure? Hydrostatic means the pressure pushing fluid out. Oncotic means protein pulling fluid back. Basically, this is influenced by systemic factors, but they are not influenced by direct pleural damage. Think of it is as leaky due to whole body issues like heart or liver problems. Major examples are left ventricular failure and cirrhosis. What is exudative effusion? These are protein rich, often cloudy fluids from increased capillary permeability or inflammation in pleural area. Local factors dominate like infections or tumors, damaging vessels or blocking lymphatics. Major examples are bacterial pneumonia, malignancy, viral infection, and pulmonary membrane embolism. How are you going to diagnose your pleural effusion? Always start with thoracentesis, which is your fluid aspiration, and then you are going to use Light's criteria. This is very important. What does Light's criteria say? By doing Light's criteria, we can say whether this pleural effusion is exudative or transudative. First, what does Light's criteria include? First one is pleural fluid to serum protein ratio should be greater than 0.5, and next one is pleural fluid to serum LDH should be greater than 0.6. Pleural fluid LDH should be greater than 2 by 3rd upper normal serum limit. If any one of these meets, then you can say the pleural effusion is exudative. If none of this meets, then you can say pleural effusion is transudative. Next, additional steps include to measure pulmonary pleural fluid glucose levels. Then you can do cytology or differential cell count, or you can do culture, or you can check the marker for TB also. If glucose level is less than 60, you can consider malignancy, bacterial infections, rheumatoid pleuritis. If still there is no diagnosis, then you are going to do spiral CT or lung scan. By this, you can check if there is pulmonary embolism. If still there is no diagnosis confirmed yet, then you can check a marker for TB. If it is confirmed, you can treat for TB. If still you can't diagnosis and still symptoms are not improving, then you are going to consider at last the thoracoscopy or image guided pleural biopsy. Now let's zoom in on specific causes and treatments. First one is effusion due to heart failure. The most common one is left ventricular failure, often bilateral. Then what is the treatment? Treatment is thoracentesis only if it is a large transudative effusion and not responding to medications. Next one is hepatic hydrothorax. This affects 5% of patient who has cirrhosis and ascites. And here fluid moves directly from peritoneum through small diaphragm openings into the pleural space. Next one is parapneumonic effusion. This is often associated with bacterial pneumonia or lung abscess or bronchiectasis. If it turns into empyema, which is pus in the space, you need to do thoracentesis. If thoracentesis is not like if it doesn't respond to thoracentesis, then you can do test tube with combination of fibrinolytic agent and deoxyribonuclease. Next is effusion secondary to malignancy. This most common are lung carcinoma, breast carcinoma, and lymphoma. Diagnosis involves cytology of pleural fluid, or if still diagnosis is not yet confirmed, then you can do thoracoscopy. What is treatment? Treatment, there are two types of treatment. One is insertion of small indwelling catheter or tube thoracostomy with sclerosing agent like doxycycline. Next one is tuberculous pleuritis. This is top cause of exudative pleural effusion, which includes predominantly small lymphocytes in the fluid. The symptoms are fever, weight loss, dyspnea. For diagnosis, look for TB markers in pleural fluid. Next one is chylothorax. This happens when thoracic duct ruptures, accumulating chyle, which is like milky like fluid in, and most common cause is trauma. When you do thoracentesis, you can see milky fluid with triglycerides over 110 mg per dl. Next treatment is you can do chest tube plus octreotide. Alternative is ligation of thoracic duct. Next one is hemothorax. This is bloody pleural fluid. It is often managed with tube thoracostomy. Next one is effusion secondary to pulmonary embolism. The diagnosis is via CT scan or pulmonary arteriography. Treatment is anticoagulation. Next, we are going to learn about pneumothorax. What is pneumothorax? It is defined as presence of gas in pleural space. Let's expand on pneumothorax. This condition, also called as collapsed lung, happens when air enters pleural space, creating pressure that partially or fully collapses the lung. Normally, the pleural space has negative pressure to keep lungs expanded, but air disrupts it, this leading to symptoms like shortness of breath. We will cover types, causes, symptoms, diagnosis, and treatment. Let's dive in. First type is primary spontaneous pneumothorax. This is sudden lung collapse without underlying cause. Remember, without underlying cause. This often occurs due to rupture of apical pleural bulbs or small cystic spaces that lie under visceral pleura. Some they say like this often occurs in most common in tall, thin, young adults, age between 15 to 34, and these also in smokers there is increased risk in smokers also. And the treatment is simple aspiration. Alternate is, if simple aspiration doesn't work, the alternate is thoracoscopy with stapling of blebs and pleural abrasion. Next is secondary spontaneous pneumothorax. Collapse due to underlying lung pathology. Basically, air leaks from damaged lung tissue. Most common is due to COPD or also emphysema. Next treatment is thoracostomy, and if thoracostomy doesn't work, alternative is fluorodialysis plus you can give doxycycline. And higher risk is in older adults over here who age greater than 55. And next one is traumatic pneumothorax. Basically, this is caused by injury to chest wall from both penetrating or non-penetrating chest trauma. Leading causes are thoracic needle aspiration, thoracentesis, and central IV catheters. And treatment is supplemental oxygen or aspiration, and alternative is thoracostomy. Of this, remember, this is often associated with hemopneumothorax, which is the air plus blood will accumulated in pleural space. Next one is tension pneumothorax. This is medical emergency. Air enters but can't escape. Rapid pressure buildups, lung collapse, and mediastinal shift also occurs. This is often occurs from trauma due to mechanical ventilation or resuscitative efforts. This causes high peak inspiratory pressure during mechanical ventilation. This one strongly suggests your diagnosis tension pneumothorax. And when you do physical examination, there will be enlarged hemithorax with no breath sounds. There will be hyper resonance to percussion, and there will be shift to mediastinum to contralateral side. Then what is the treatment? Treatment is you have to insert large bore needle through second intercostal space. If large amount of gas escape after inserting this needle, then diagnosis is confirmed. And remember, the treatment is thoracostomy tube should be inserted, okay, but a needle should be left in place until this thoracostomy tube can be inserted. Thank you so much. That's all about your disorders of the pleura. If you like the video, please share it with your friends, and if you like the video, please subscribe my channel. Thank you so much. Goodbye.